What's the make? Who are these people? What kind of this guy picked up talking about? He's riding on and wine. There's golf. There's 4 times. Probably one of the sports now. That is just driving like he was dead. These guys are about this guy walked out. I guess it was within something he didn't get killed.
Well, you want me to call on you to introduce these guys? Would that help you any? Well, we've stuck Howard in between, but he's not going to be long. Yeah, one of them actually was born in my home where I live in Warner Robins.
They have they submitted some notes, I think. Carlton Buchanan was one. There was Todd Ziegler. Todd
Where's the bios on his 2 doctors? I don't mean to be digging through your stuff.
I've got this here now.
But we got we got Mosley next, right? Yes, he got squashed in here. We need to get back at it. Okay. All right. Everybody, could we gravitate back in the room, or maybe take our personal conversations outside where we can get back going? Wow, that's the best that's ever happened. I can't imagine. Okay, we're going to pick back up on our agenda that has been amended, and it's certainly my privilege, honor, and true delight to introduce one of my best friends in the whole General Assembly, and it's somebody that is all day, every day, in a vocational way, dealing with the issues that and some of the problems that we're trying to solve, and I'm not going to go into a real long introduction because most of you all probably already know our next presenter and speaker, but he's certainly a great friend to all that's good about healthcare, especially in this arena, right where we are here today. And I'd like to ask Representative Howard Mosby, please, to come present to our committee.
Thank you, Mr. Chairman, members of the committee. It is my extreme pleasure to be here and tell you the little bit that I do know about this particular issue. Many of you may know that I am Vice President of Medical Affairs at Grady Health System. I've been at Grady for about 12 years. I started there as an internal auditor, found out where all the problems were, and then I was moved up quickly to get me out of the way. But I've enjoyed my career at Grady, and it is indeed a phenomenal place. As Senator Edelman said, it is the busiest level 1 trauma center east of the Mississippi, and it is the busiest in this state. And I'm proud to be associated with it. And there are a number of exciting programs that go on there. But the linchpin or the most identifiable service that Grady does is trauma. And one of the things I want to talk about is the technical aspect of delivering trauma care at Grady. Having a trauma network will be beautiful in this state, but if you don't have a trauma service in the hospital, then it would mean nothing. One of the challenges that we face at dealing with things at Grady happens to be with trying to educate the public on what's the difference between an emergency room and what's the difference between a trauma center. And in an emergency room, you're looking at broken legs, back sprains, broken ribs, lacerations, and concussions. But in the trauma center, you're looking at multiple fractures, paralysis, punctured lungs, stab wounds, brain injuries. These are some substantial things that we do, and you have to have a slew of professionals to be able to deal with that. Some of the things that we deal with at Grady, if you look at the percentage of the business in our trauma centers, you're looking at motor vehicle crashes being about 60% of the business that we do there. And then you're looking at falls, assaults, burns, around 3%, recreational accidents, and believe it or not, suicide is another one of the issues that we have to deal with. And these are things that places like Grady have to deal with. So when you look at that environment, what is it that you have to do to bring support in that environment? What we're finding is that we're finding a lot of our medical staff wanting to get out of that. Although we are a teaching hospital, it's very taxing on our medical staff to do that. In maintaining the medical staff participation, I'm going to read this right quickly so I can talk about my little points. Maintaining medical staff participation, trauma care is increasingly difficult in both community and academic hospitals, which is what we have here at Grady. And there are many contributing factors. There's a reduction in resident support. We're finding that there are a lot of residents that don't want to train in trauma, and due primarily to the kind of lifestyle that you have to live to be a trauma surgeon. A lot of those guys practically live in the hospital. And if you're not ready to do that, you have young children and you're trying to establish yourself, you don't want to spend a lot of your time in those hospitals 24/7 in a lot of cases trying to be a trauma surgeon. So a lot of residents are electing to get out of that. As Dr. O'Neill said, a shortage of trauma surgeon specialists. We're seeing a lot of that. We're seeing anesthesiologists, we're seeing radiologists, things that provide support to the trauma service, that we're seeing shortages in those areas. And as Dr. O'Neill stated, the incompatibility with private practice. Trying to get doctors in private practice to support the trauma service is becoming increasingly difficult. As a matter of fact, there are the on-call charges that doctors are charging hospitals is becoming outrageous. And when you set up this trauma network, you'll find yourself down the road having to bankrupt that network just to pay doctors to be on call. So that's one of the things that we got to look out for. And as I said, undesirable lifestyle to do trauma call. Malpractice, that's another big issue. EMTALA, we talked a little bit about EMTALA. EMTALA is interesting in that the federal regulations that required hospitals to treat patients in the hospital and in emergency capacity, there were some changes made that allow for hospitals, if you have a surgeon, if you have a service that doesn't have that particular specialty, you can stabilize the patient and then transfer that patient out to a trauma center. And Grady, we do see a lot of that. And I'm trying to be politically correct here with Austin Scott's question here. But what I can tell you is this. Hospitals can say, we don't have this specialty. We can stabilize you, and then you need to go. And you see a lot of that. And that's all I'm going to say about that. I don't know if that has anything to do with money, but
Yeah.
but I hear you. And then you have managed care out there. And managed care, there's some debate about how well it reimburses for trauma care. A lot of times, how many of you in here plan to be in a traumatic incident this year? But how many of you plan to see your doctor this year? So it's, oh, that's the same number. Okay. So in looking at trauma, it's hard to say, you know what, we're going to set up a service to deal with this, and we're going to be able to deal with these types of injuries that are going to come through. You just don't know. You just don't know. And you can get some minor injury like a broken leg or a laceration, or you can get a gunshot wound to the head where you have a patient that you're going to have in your hospital for months trying to rehabilitate that person. And who's going to pay for that? And then your downstream care and your ICUs and your rehab. So we have to really make sure that when we look at our funding our trauma networks, that the supporting pillars to that network, your trauma centers, are making sure that they are viable themselves to make sure that they can take care of our state citizens. Some of the top economic threats, the underserved regions. That's a top economic threat. Trying to make sure that on that map that we have trauma centers placed in strategically located areas. The medical staff support, as I said, unfunded care, that's a big issue, and trauma physician compensation, as I stated, that's a big issue. Now, academic trauma centers, which Grady is, I want to talk about specifically here, that a lot of those departments have suffered from reduced payments, and they are losing their colleagues to private practice. And it's really threatening the supply of doctors in the pipeline to be able to provide trauma care in the future. So when we look at this network, you look at what is it that's going to be available for us in the future. And if we're not having doctors being trained in this arena, then we're still spinning our wheels here. So let's make sure that facilities like Grady, when you're looking at trauma care, that we look at those supporting things, those supporting funding mechanisms to make sure that the system and the service itself is there. As I said earlier, 59% of the patients we treat in the emergency room come from car accidents. But insurance companies, car insurance companies, probably reimburse Grady right around 7 to 10% of the cost of providing that care. And it's unequitable. What happens is that those insurance companies get to negotiate their rates once that person hits the hospital, and it's unfortunate that happens, but they tend to penalize these trauma centers because they don't have sometimes contracts with those insurance companies to do that. So, but it's a fragile network, and we want to make sure that Grady is there in the long term, especially from its provider standpoint, to make sure that we treat our patients and treat the patients in this region with the right and appropriate care. And with that, Mr. Chairman, I said I will keep it brief, and I will welcome any questions from the committee. I did that good? Oh.
We look forward to visiting with you.
Absolutely. Absolutely. Thank you. All right. Okay.
I'm sorry. You ready? We said that roughly 60% of Grady are from car wrecks. And the insurance companies are reimbursing 7 to 10% of the cost. Mm-hmm. What is the average cost of care for a car wreck incident at Grady? Do we know? I mean, I know that you can't know every statistic someone's going to ask you for, but
yeah, I don't know right off the top of my head, but I would say that we're probably reimbursed somewhere around 70-80% of the cost of the care, not the charge, but the cost of the care.
Cost of care would be, I guess what I'm getting at is med pay limits and things that.
On car accidents, no. It kind of depends on if it's a rollover.
Sure.
I don't have that information in front of me.
Senator Davis?
Thank you, Mr. Chair. Thank you, Representative Mosby. Can you talk a little bit about how the establishment of a statewide trauma care network and the addition of new trauma centers to the state would benefit the existing trauma care centers, and especially Grady, by taking some of the pressure off Grady?
Thank you for the question. I personally believe this, that if you look at Metro Atlanta has half of the state's population in it right now. There's only one level 1 trauma center, and that's at Grady Hospital. Now, I'm going to say this as a piece of commentary. Shame on the other hospitals for allowing that to happen. They profit. I want to stand back, but I think that they profit off of the fact that Grady is here doing that kind of work. I think putting together a statewide trauma network, you begin to start, as Dr. O'Neill said, looking at what areas are going to handle what specialties at what particular point in time. So it's not all put on Grady right now to do all of this in this particular region. And so I see that network helping Grady be able to divest itself of some of the, handling a lot of the trauma 100% of the time in this particular region.
Yes, sir. I have a couple of questions.
Sure.
And mine goes to Senator Adams. We talked about the underserved areas, predominantly in the south of rural counties that don't have it. But yet, I represent a county that has almost 800,000 people. And if you look at Gwinnett County, Cobb County, the affluent counties, with major interstates and these car accidents that you're talking about, when you have an accident in Gwinnett County and you cannot go to the hospital that's 2 miles away and you get diverted and go to Grady, I want to know if you can provide the committee with the statistics. And off and on in the newspaper, I've seen these statistics of how many people are transported from the urbanized areas, Cobb County, Gwinnett County. They have almost 1 million people down to Grady. Can you give us those statistics?
I don't have them off the top of my head, but what I can...
You can provide them to the committee?
Absolutely. And we know that the cost or the amount of uncompensated care that we're providing from the metro area is substantial, in the tens of millions. So, and we can provide that information to the committee so that it can have that.
The other question I have is, if you look at these counties, if you look at Cobb County, Gwinnett County, Fayette County, this is the area right where they're building the new hospital, Johns Creek. This is where these subspecialists are living.
Mm-hmm.
So what is the excuse for these hospitals in this area that have the medical staff that they cannot be trauma 1 care?
That question might be better for Representative Scott. I think that, as I stated in some of the points that I made in the talk, that trauma is not easy, and it really goes against having a normal lifestyle. And when you dedicate yourself to being a trauma surgeon and getting in the trauma business, that you dedicate yourself to saying, at any point in time, I put my life on hold, and I'm going to treat patients that come through the door. And there are a lot of physicians now, and this is a different generation of folk that are coming up now that want to have a higher quality of life, and they're not willing to make those kinds of sacrifices.
And one other question. I grew up here in Atlanta, and when I was growing up, if you had an accident, you automatically went to Northside Hospital. I lived on the north side of town. And how over, I don't know if you can answer this, a historical period, did Northside, it became like a labor delivery, a profit-making facility. Why did it not stay in that trauma emphasis? I mean, is there a reason?
Well, they were making more money in labor and delivery. You're absolutely right. What happened in the mid-'80s was that trauma became it came into light. You remember, trauma came out of the Vietnam era, and a lot of the docs that came back out of Vietnam wanted to set up the same type of triage systems in hospitals. And during the 80s, that specialty took off. And because we're an academic medical center at Grady, a lot of the docs wanted to train in trauma, and we got a specialty or an expertise in that area. At the same time, reimbursement for deliveries shot up, and it looked interesting for those hospitals to say, look, let's take on OB and do some of the deliveries instead of doing some of this other work that we were getting marginally reimbursed for. And so I see hospitals like Northside jump into the arena, St. Joe's and Cardiac, to say, you know, we're going to develop those product lines instead of going after trauma.
And just a side note, I have to say that I think it's just incredulous that physicians that you train in Grady, who are well-trained physicians, then move to the suburbs and won't take care of the people that they were trained to take care of.
I hear you.
Thank you. I want to ask you this question, but I'd like others, as they address this committee, to address it also. Is there a relationship, as we study CON, between CON and the ability to provide trauma care, and if not, should there be?
I get to weigh in on that one. One of the threats to the trauma, to attracting people into trauma is doctors that can go into ambulatory surgery centers and do that type of work, cosmetic surgeries, sports medicine, things of that nature. And as they are able to set up their practices close to hospitals like Grady, you'll see Grady see less and less of that type of business come through the door and more of the uncompensated or poorly compensated services go to the hospital, in my opinion. I don't have any facts on that, but that's kind of how I see the lay of the land. How does that affect on the CON debate? I am a legislator, and I just, right now, I don't really see the correlation. I hear you, I understand the question, and I have to think a little bit more about it to give you a fair answer.
Representative Mosby, certainly do appreciate that presentation, and again, we look forward to seeing you later on today over at that wonderful facility that you work for that does so many great things for us. Senator Staten, would you introduce two physicians that are going to talk to us?
Our next presenter is Dr. Carlton Buchanan, and we invite him to come forward. Of interest to Chairman O'Neill and myself is the fact that he was born in Warner Robins, Georgia, at the Warner Robins Air Force Base. That's a very impressive credential in and of itself for those of us who serve the districts down there. He attended the University of Florida for his undergraduate work, College of Liberal Arts and Science, and then the Doctor of Medicine degree from the University of Florida as well. He is chief of the Department of Emergency Medicine for the Gwinnett Hospital System, also serves as Assistant Medical Director and Chief Medical Information Officer. We welcome to give testimony to this committee, Dr. Carlton Buchanan.
Thank you. If it makes any of you Bulldogs feel better, my wife did go to Georgia, so it kind of negates some of the Gator issue. Well, he told you who I am. Where do I come from? Well, I'm at Gwinnett Hospital System, and Gwinnett Hospital System is primarily made up of Gwinnett Medical Center in Lawrenceville and Joan Glancy Hospital in Duluth. Gwinnett Medical Center is a level 2 trauma center. We see approximately 600 trauma visits a year. Now, I'm talking about 600 trauma team activations, These are serious injuries. We in 2005 saw just over 100,000 visits in our emergency room. That puts us in one of the top 3 or 4 emergency rooms by volume in the state. Our emergency room alone is 63 beds just for the emergency room. Unfortunately, we only have about 188 licensed beds to take care of those patients. So when we talk about CON issues, I'd be happy to talk about that. In 2005, we did just a little bit over $40 million in indigent care, and that's cost, that's not charge. So just to keep it in terms that people are familiar with. We rarely go on diversion, and fortunately, we rarely transfer people down to Grady. We're lucky in that. Just briefly, I like to talk about, there's been a lot of talk about trauma care, and I just kind of like to give my 2 cents on it. You know, trauma care is feast or famine. You have to be prepared at all times whether the patient comes or not. And with that, you eat up a lot of resources. We've talked about trauma care a lot today, but I'd like to talk about really what that means. And that means having available emergency room beds, CT scanners, a CT tech there 24 hours a day, an ultrasound tech, and an ultrasound machine that are ready at a minute's notice, available operating space, available ICU space, and surgeons of all specialties. And we talk a lot about we're going to move this patient to here, we're going to move that patient there. In trauma, we talk about the golden hour, that people need to get to definitive care within 1 hour. So all those things have to be available immediately. They can't come from home. Unfortunately, some of the inherent problems with trauma is it does occur at odd hours. People have talked about the 3 a.m. call. In a little bit, I'm going to talk about why the 3 p.m. or the 11 a.m. call might actually be worse than the 3 a.m. call. But it's trauma care, because of all the resources that are needed, it is extremely expensive. And you've got, as they mentioned, the initial acute care, you've got the long-term care and management of these people in the rehabilitative setting as well. And unfortunately, trauma care is seen, whether true or not, it's seen by the subspecialists as high liability. And so I'll put my plug in here that I thank you very much for the tort reform that passed in 2005. I'll specifically mention the emergency department care provisions. I've heard over and over in medical executive groups or other groups where one specialist said to the other, yeah, but at least with the tort reform, when you come to the emergency room, you've got a little more protection than when you see that patient in the office. And I hope that the legislator and the courts let us keep that. Trauma is not a real good, particular good payer mix. When you look at the patient, whether the patient's going to have insurance or not, it's really not a good payer mix. And one of the issues there is penetrating trauma. Now, your mixture of, when I talk about penetrating trauma, I think it was mentioned the interception of a bullet or a knife, but that is different from blunt trauma usually in your payer mix, and it's not hard to figure out why that is. Over the last 4 or 5 years, we've also seen another thing that's affected the trauma mix, and that's really the illegal immigrant issue. In Gwinnett County, we have a tremendous amount of growth, we have a tremendous amount of construction, and we have a tremendous amount of construction injuries. And the reality is a lot of those people are illegal. And I joking that when I hear that somebody's fallen 20 foot, and they say, if we call the trauma surgeon, I say, if you call the translator, because that's really the truth most of the time, that you need a translator. And unfortunately, that particular patient population doesn't fall under workers' comp and doesn't have a health insurance. So that's a big problem. One of the issues with trauma care is it really requires a special expertise that really cannot be provided at just academic centers. We've all seen that map up there. We know how many academic centers in this state there are. We also know geographically how big this state is and how many people are there. And it just can't be covered by just academic centers alone. It would be great if it was. There's lots of residents there. You've got people that are in-house 24 hours. It's part of the mission. You've got people that are happy and excited when they see a patient that they know they're going to get to operate on 6 times in the next year. That's not the way it really works in the community setting. And unfortunately, people have got to be, trauma care is going to have to be delivered by the communities as well. And the problem with that is it's not optimally managed by the general community general surgeon, orthopedist, ENT, or plastic surgeon. And this is not to speak disparaging of any of these people. I've learned this over the years from them. What happens is a guy gets out of his residency in let's say, plastic surgery, and he's just done all the big cases, he's done all the tertiary stuff, he's fired up for anything that first 6 months and happy to take it. 5 or 6 years down the road, that person's developed a community practice of plastic surgery. And now they're faced on a Monday morning or a Saturday night, it really doesn't matter when, but somebody who's got multiple complex facial fractures that may need 4, 5, 6 hours of surgery, and it happens to be a surgery that they haven't done in 4 or 5 years. That certainly presents some angst for people. So you've got to look at how are you going to train people. There are specialized courses that people go to do traumatic orthopedist, plastic surgery and general surgery, but that takes time and it takes money and it takes commitment. And it's just one piece of the thing that makes trauma care difficult. This has been touched on a lot today, and I'm really happy, but there's one thing, if you guys take away one thing from me, it's that I'm selfish. I'm here because I've got 3 kids and a wife and other relatives that live in this state, and trauma care is about all of us. And we all like to think that if we have a bad injury or, a brain tumor or a heart problem, we're going to research on the internet and find the best specialist at the best place. When you get crunched, either going to Disney, on 75 on your way to Disney World, or out on 316 going to one of the Georgia games in a couple of weeks, your trauma care that you're going to receive then is going to be determined by the commitment that local system and local physicians have made, and you better hope that it's a good one. That's the one thing that I think we need to take away from this, because the helicopter, it's glamorous with the helicopters and everything, but it's a lot of times they can't fly, and when they're called, they also are eating up that golden hour. You want to get to somewhere where they've made a commitment to take care of you. And we can talk about what a commitment really requires in a minute. Tom mentioned to me I was told I need to talk about some everyday problems. Now, I'm an emergency room physician, so I see trauma patients, and my job is to stabilize them, identify their injuries, and get them to the appropriate specialist to take care of them. And I kind of joke at that point that I'm sort of a salesman with a not too good of a product when it gets to that point on the phone. Kind of top-down problems for me definitely is one of these is the lack of statewide coverage. I thank you guys for SB 565 and all the process that you're undergoing. I think covered in those gaps is great. I like what Dr. O'Neill said. We add 10 or 15 trauma centers. What I'd like to see is that map up there, and each hospital has kind of a radius that's their catchment area, and someday all of those areas being covered with a little bit of overlap instead of big areas that are uncovered right now. There's been talk about developing a trauma system. I think right now we need to stabilize the trauma system. It is, somebody mentioned the word fragile earlier, and I don't think that is, I think it's probably about the best description that I could hear, because if you look at the numbers of trauma centers, it's going down. And the first thing we need to do is stabilize the existing trauma centers and make sure they're fully functional. And I'll show some examples. And then move to expanding it, because this is a fragile system that I think it's in pretty rough shape. As I mentioned, the finances of trauma is a problem. Trauma is a money-losing venture. If you want evidence of that, look at the current 15 hospitals that are trauma centers. There's, to my knowledge, and somebody can raise their arm and correct me, but there's one for-profit hospital in there, and that's North Fulton. And I don't know if anybody's here for them. I applaud them that they've been doing trauma care for a long time, and they're in it to make money, but I don't know of any other hospital that's for-profit that's doing that. One of the biggest problems that I deal with day in and day out is hospital overcrowding and diversion. There's no surge capacity. There's no surge capacity in this city, in this state, or this country. Over the years of managed care and tightening the budget, hospitals have just closed beds, and hospitals have closed and they've cut their numbers of beds. At Gwinnett Medical Center, for the year, we have run 108% of capacity. So somebody calling and saying, do you have a bed, is just never an answer. We just don't. This is where that CON question fits in. I think if you're going to have hospitals that are going to go the extra mile to take care of trauma patients and be a part of that trauma center process, they may need to have some special leeway in getting getting extra benefits from the CON system. I think if you want people to pay money towards that $250 million worth of uncompensated care, they got to be able to make it somewhere else to pay for it. Diversion is a big problem. I think that a minute ago we had it up there on the screen, the number of areas that are diverting. This is a big problem for us because patients are diverted from other facilities. We rarely go on diversion. We've made a commitment that if it's not for a specific person, a trauma surgeon in the OR or a neurosurgeon who's in the OR, we're not going to go on diversion because we're oversaturated. I'm hoping I'm not going to look up there and see us on diversion, but I think we spent less than 100 hours on diversion last year because of that commitment. But what happens is when you don't go on diversion, you're almost punished because people go to this list, and this looks pretty good compared to most days, and they start looking to figure out where they can divert. And I've had people come, via ambulance from Forsyth County all the way over to Lawrenceville, and actually even Cherokee County, because every step of the way somebody has been on diversion. So that's a big problem because what happens is as more people take themselves out of the system, the people that are left carry an even bigger burden. The other issue is when you can't divert or can't transfer to other facilities. I've had numerous patients that have had spinal cord injuries that need to be stabilized and also need long-term management that when I called Shepherd as an example, they're happy to take care of the patient. They don't have any room to take care of the patient. We have, I think Dr. O'Neill mentioned transfer agreements. At Gwinnett Medical Center, we don't do open heart bypass, and I'm going to put a plug in for that later, but we don't do that. So we've made a transfer agreement with Atlanta Medical Center to take all those so that we can cut through the paperwork and we can move patients who have an aortic injury after a car accident who may need surgery in minutes to hours to get those people out quickly. Several months ago, we have a patient just like that, young patient, 18 or 20 years old. AMC, Atlanta Medical Center, was full. They wanted to take care of the patient. They've got no room. We had to call 3 different places, and I believe that patient ended up in either Macon or Augusta. We actually contemplated sending that patient out of state as well to get taken care of. So the diversion and the overcrowding and the lack of surge capacity affects all of us at every part of the way. The issue that, and what I would talk about real quickly is you see this Henry Medical Center, it looks like they're saturated in their ER and CCU. They have no neurosurgeon. AMC is going case by case, and they have an ER full of ICU patients, which means that you've got an emergency room nurse who's trying to take care of an ICU patient and take care of their other patients. DeKalb has no neurosurgical coverage until August 17th. I don't know how many of you know this, but DeKalb has basically, I think as I told Dr. Hardcastle, 1.5 neurosurgeons. So they figure somewhere between 13 to 15 days out of the month, they have a neurosurgeon. Otherwise, they don't. So plan your accidents accordingly if you're on 285 in that area. But that's pretty scary that almost half the time, if you're in an accident there, you're either going to Grady, you're coming to Gwinnett Medical Center, or you're making a long trip around 285 up to North Fulton. But that's real, and that's going on right now while we talk. I don't really do a lot with Medical College of Georgia, but it looks like that reimplantation revascularization service is not available either. So you see the kind of difficulties that we have. One of the problems is, as it's been mentioned, and I'm really glad to hear this, is lack of specialists. And this is important to me because I'm the guy that's got the patient, and I'm trying to find somebody to take care of that patient. And it is very difficult for trauma surgeons to recruit. I'm just going to give you a couple numbers here. You've got DeKalb, who kind of has 1.5 neurosurgeons. We have 3.5 neurosurgeons. The reason I say the half is 3 are required to take call, and the 4th one is old enough that he doesn't have to take call, so he's compensated for it. Last night, when I was looking on their various hospital websites, I found that Northside has 10 on staff, and Piedmont has 7, and St. Joe's has 5. Now, I'm not pointing any fingers at anybody, but just imagine how difficult it is. Do you want to be the 3rd neurosurgeon at DeKalb and be on call every 3rd night? You want to be the 5th neurosurgeon at Gwinnett Medical Center and be on every 5 nights? Or do you want to be at Northside and be the 11th neurosurgeon on staff at a place that doesn't take trauma through the trauma system? It's not hard to figure out why the trauma system is set up. It makes it very difficult to find specialists. The same issue happens with orthopedic surgeons at our hospital. our orthopedic surgeons were not only complaining that they were having to take call at a trauma center, that it was making it very difficult for them to recruit other physicians, other orthopedists, just to practice the general orthopedics, because they knew they're going to have to take call at the level 2 trauma center with 100,000 emergency room visits. And our solution was to form an orthopedic trauma service to take that burden off of the community orthopedist. And Dr. Ziegler is going to talk about that in just a minute. Hand surgeons, plastic surgeons, it's the same thing. And what you need to realize is hospitals are competing not just for patients, but for specialists. The examples of Johns Creek. Johns Creek, we have a new replacement hospital for Joan Glancy called Gwinnett Medical Center in Duluth, that obviously is going to be in Duluth, and we're going to be competing not just for patients, but for specialists with Johns Creek. And when people look at it and they say, well, I can be on staff at Gwinnett Medical Center in Duluth and also have to take call in Lawrenceville, or I can go over to Johns Creek, people are making lifestyle decisions. Now, the next issue is even if you have the specialist, you've got to find the specialists who are willing to take care of trauma. And I've been doing this long enough, and I've talked to enough people that I understand it, and it is very difficult. We talked a lot about that 3 a.m. call. I will argue that the 11 a.m. call is much worse, because when somebody's called at 11 a.m. on an emergency case that they either need a general surgeon or an orthopedic surgeon or a neurosurgeon, that they need to go take care of that patient immediately, they're canceling their office for that day. They're sending all the patients and the resultant income home. Guess what? Their staff is not going to go home unpaid. So those people are going to be paid while they're leaving, and that physician is going to the hospital to take care of somebody that they may or may not be compensated for. So I think that's a very big issue. There's also long-term supply costs. We a lot of times think of it's just your time and, well, it's 4 or 5 hours, whatever, to take care of that patient. It's not just that. Somebody who has had either a neurosurgical or orthopedic injury, that person's going to need multiple splints, they're going to need multiple dressings, and they're going to come back to that person's private office. They're not going to come to the hospital to get that done. Any repeat x-rays, those things happen in the office, and they have real costs. So you kind of move from the charge world and time world to actual costs. How have we handled that? At Gwinnett Hospital System, it's fortunate that our hospital administration has made a commitment that we're going to provide trauma care. And I got to tell you, it was difficult because we moved from a level 3 to level 2 a couple years ago. And I mean, I had to pretty much arm wrestle some of the subspecialists over it as they're saying, why are we going to do this? Why are we going to get more helicopter patients? But nevertheless, our hospital administration has made that decision, and it's resulting in us basically hiring 3 full-time trauma surgeons that just work for the hospital that take care of trauma patients, and compensating an orthopedic trauma service, neurosurgeon, and hand surgeons. This has resulted in about a $2 million per year, or likely greater than $2 million per year being paid in physician compensation alone to take care of trauma patients. And when you understand what a commitment about making sure that you have a hand surgeon means, we make sure that we have a hand surgeon every month. Another hospital that's in our county, that's a for-profit hospital, will go at least half of the month without any type of hand surgeon. And effectively what happens is when an emergency room physician in that hospital has a person who needs a hand specialist, they simply call over to our hospital, ask who's on call, and because of the EMTALA rules, if you have the facility and you have the person that can take care of that and another hospital doesn't, you're required to. So that's sort of how some of this making a commitment, what kind of burden it can apply on you. When I mentioned that $2 million and what we're doing, that's really just keeping it together. That's keeping people from leaving our hospital. That's keeping people from going to courtesy staff. That's allowing the other specialist physicians to keep recruiting people. I suspect the future is that we'll probably have to do that in other specialties as well. Lastly, I just want to mention on the issues of day-to-day things, every once in a while, I do see the patient that requires emergent cardiac bypass. And what I'm talking about is other than significant burns, at a level 2 trauma center, Gwinnett Medical Center, the only injury that we really can't take care of is somebody that needs an emergent bypass and have their aorta fixed. So keep in mind that, if you're on 316, you're going to the Georgia game, you're going to Athens or whatever, and you have an injury and your aorta tears, we stabilize you, find that injury, and we still have to transport that patient to somebody that has bypass. So I suspect in a couple more years I may be back asking for legislative support to get bypass in more than just a couple of places outside the perimeter. Like I said, I think we'll probably be back for that. Obviously I'm up here like everybody else saying, we need more money for this system. We need to stabilize. It's in crisis. Where does that come from? You look at that trauma study development committee paper that I think Dr. O'Neill provided. It's got an excellent list of multiple potential sources from it. I'll mention two things. One, I think that there's a precedent in this. We talked about how many trauma patients there are and whether insurance companies decide whether they want to pay for them or not. In other situations, a legislator has said you're going to pay for mammograms, you're going to pay for vaccinations, and things that if you're going to do business in this state as an insurance company, you're going to do. I think that something that we could look at in the next session is making mandatory carve-outs for trauma activation fees. And what that is when somebody is deemed by American College of Surgery guidelines to be a trauma, we do a trauma team activation. That means that the x-ray tech stops and comes in the room, that I'm waiting in the room, that at least one or two nurses is awaiting in the room, that the general surgeon is notified, that the CT scanner is putting the next patient on hold waiting because we may bring that patient over, and that the ultrasound tech is probably pushing the ultrasound machine down there. A lot of manpower involved. When we do that, we do charge a trauma activation fee. That's a fairly significant charge. I think that if one thing that would help us right away would be if insurers had to pay that. It would only be used by the trauma centers, which is good. I don't think there's much potential for abuse there, and I think it would go to the places by volume, which is what you want. The more you do, the more you get compensated for it. The other thing that I'd like to throw my 2 cents on is photo enforced tickets. We're seeing, and I know I've already talked to Tom about this, I've talked to Abel Ortiz about this. We're seeing a mushroom of photo enforced ticketing, and I think we're going to see that all over the state, especially when we have companies that have a profit incentive to sell those to municipalities. That, and my feeling, is unbudgeted money because it's all going to be developed in the future. So you're not taking it for anybody. I think that a surcharge or a piece of that could be a constant increasing revenue stream for trauma services. And with that, I'd like to mention one thing. There was some talk about diversion on the last thing. I'd like to clear up a little bit transfers versus diversion. I think Representative Scott, there's a difference between somebody getting to your facility and then you making whatever triage decision that you want economically or not, which is I think you alluded to transferring that patient to another facility. That's somebody that's in your facility. When we talk about diversion, we're talking about publicizing the EMS in the pre-hospital setting. Hey, we're not open for business. I think that's a very big problem in this state, and I think it probably needs to be looked at the state level, and there needs to be some guidelines, because I got to tell you, there's a lot of people that are up there. Every time you flip it on, they're on diversion for one thing or the other. A lot of people have very low thresholds for going on diversion, and I think that there is an economic incentive to look at it. If you know the payer mix of the patients that arrive to your facility by EMS, then you don't have to figure out. It doesn't take you long to figure out whether you want to be in the business of accepting all the EMS patients or whether you want to limit those at every turn. And I think that I do feel like that's a concern.
Thank you, Dr. Buchanan. We appreciate it. If you would stand by, because we're getting close on time. But let's go ahead and bring up Dr. Todd Ziegler, who is an orthopedic surgeon, did his undergraduate work at Florida, and is also an MD, University of Florida. He is the director of orthopedic trauma, the orthopedic trauma program at Gwinnett Medical Center, and we welcome you, Dr. Ziegler, keeping in mind that we're running a little short on time. Thank you.
And I just want to thank you all and Representative Rice for inviting us to come and talk. I'll just abbreviate this and make it very quick. One thing I wanted to address was your question about auto insurance earlier. One of the problems we have with auto insurance is our patient population who tends to be involved in auto accidents is much more commonly the Friday night intoxicated patient who runs into a tree as opposed to the person at work going home on Friday evening. These folks tend to either carry no insurance or often the minimum, which is liability coverage for their passengers, people they hit, but not for themselves. So a lot of your auto insurance is not going to cover the care that is trauma. And when you asked about the hospital bills, those bills for a single patient who may have 1 or 2 surgeries, be admitted for several days, easily $25,000, $50,000. So $5,000 or $10,000 of med pay coverage doesn't go very far. What I want to do is just give a little perspective on what it's like to be a community physician at a level 2 trauma center, Gwinnett Medical Center, which Dr. Buchanan's been talking about a little bit, and the challenges we face there. In a community hospital, we're kind of talking about the fact that we're not an academic center. We don't have residents. In a hospital that is a teaching hospital and has residents, they may have multiple layers of coverage for nighttime calls. So when a patient comes in the middle of the night, there may be an intern or a first-year resident who goes in and takes care of the very simple stuff. If they need to go to the OR, a higher-level resident will come in. At times, an attending or a practicing physician will come in and be involved in that. But a lot of the nighttime responsibility goes to the residents. We have none of that. So we're all alone. So everything from a bad cut that I need to go in and deal with up to the very severe trauma patient I'm responsible for. So when we're on call at a facility like Gwinnett Medical Center, it's a constant thing. These vignettes that we've talked about stories of patients and bad outcomes, not the bad outcomes, but the patients happen every day, several days. So it's not like we're on call and maybe I'll get called in tonight. I'm on call, and if I get to go home and get some sleep, I'm pretty excited. My goal is to try to be home a little after midnight. And I may take call. In the past, I've taken 8 call nights a month. Now we've got a system in place where I'm down to 4 or 5, which seems to be somewhat manageable from a lifestyle perspective. But I'm an orthopedic trauma interested surgeon. Your average orthopedic surgeon has very little to no interest in being up late at night, disrupting their private practice. And there's a lot of hurdles. The fact of the matter is that it's not a good marketplace to do trauma. There's nothing in place compensation-wise to stimulate or make somebody want to go into that field in the state of Georgia. In other states, other situations, people have put incentives in place, and trauma surgeons or trauma-trained surgeons are migrating to those places. For example, we had an orthopedic trauma surgeon trained to do pelvic and acetabular work, Robert Harris, down at Atlanta Medical Center. Very important resource for the metro Atlanta market. A lot of doctors, our facility included, when we would get very complex pelvic and acetabular trauma, we would call up Robert and he would accept the patients down and fix them for us. With his departure, we have a huge void, and he went to a facility in Tennessee. And a big part of that, and you'd have to talk to him personally, is he had a better guarantee of compensation, that he knows when he works late at night he's going to get paid for taking care of uninsured patients. We need, or at least in my opinion, to create a market by which doctors want to take care of trauma patients. It's not looked at as a burden, which is what it is now, but it's looked at as a burden that's manageable, because you can have a commensurate practice with the doctor who's doing elective cases. It's very difficult to convince somebody to go in and do trauma work when they can work a 9 to 5 elective practice and make more money. Not just the same amount, but more. Wanted to give just a couple examples of some cases just to personalize this a little bit. Just from last week in my practice at Gwinnett Medical Center, typical situations. Had a patient, typical uninsured patient, has a compound leg fracture or open tibia fracture is what we call it. This patient may not even have registered on the trauma network, may not have been a severe enough injury to be included in the statistics. But from my standpoint, he's very important. I'm going to allude to something I need to say also is, when we talk about getting community orthopedists or other specialists involved in trauma care, it's one thing to coerce them in one way or another or incentivize them to come in and take care of trauma patients. But you also need to be aware that you don't want your general orthopedist who takes care of a trauma patient once every few months in there with these severe patients. At least that's not the optimal situation. You'd like to have people who are specially devoted to taking care of these things. And even though those folks may be in short supply and can't cover the emergency room every night, other doctors can do the initial work, transfer the ongoing issue to a subspecialist. And in orthopedic surgery, our problems don't end the night the patient comes in and gets stabilized and their life is saved by the other surgeons. That's when they begin for us. Patients may come in, may have their spleen removed, have lung injuries. The trauma general surgeons stabilize them. Then they turn them over to us to fix up their broken bones, which may be multiple. So we may be faced with multiple surgeries. We may be in a relationship with this patient for 1 or 2 years. And in the uninsured patient, we're actually paying to take care of this patient. When they come to my office, I'm paying to put the cast on. I'm paying my staff to take care of this patient, often with no recourse for reimbursement. Just going back to this scenario, a patient comes in with a compound fracture. Another orthopedic surgeon takes care of them, does a few operations on them. This leg gets infected. When this is a situation, you're talking about potential amputation of a leg with these kind of injuries. And these are not rare injuries. They happen all the time. So they involve me as the trauma specialist at our institution. And what I need to get this patient properly cared for is I need a plastic surgeon who's comfortable and good at doing free flap work, moving a piece of muscle from another part of the body to cover up this patient's open wound. Plastic surgery, very hard to convince somebody who can do an elective practice to come in and do 5- and 6-hour cases on an uninsured patient. So this patient sits in our hospital while I work to try to find somebody to take care of this patient. And this patient's my responsibility. I still am legally liable and ethically, in my opinion, liable. I want to get this patient better. So what I'm asking is to help us provide the resources to do that. Another similar case came in last week, an acetabular or hip socket fracture, very complicated injury. Only a few doctors take care of these patients. Dr. Harris down at Atlanta Medical Center would have been our typical referral place to go for this patient. Another doctor was taking care of him. Again, they asked me to help in the situation. We don't have somebody at our institution who can do these kind of cases. So they're sitting at our institution while we doctor shop, basically, to try to find somebody to take care of this patient. We would love to have somebody at our facility to do this type of surgery, but those folks, again, are in very short supply. And if there's no financial incentive to bring them there, they're not going to come. In fact, what they're going to do is they're going to leave like Dr. Harris did to go to other states. My personal reflection on this, I've been working at Gwinnett Medical Center for 7 years now. I've done a lot of the trauma burden. I'm excited by the fact that we've started an orthopedic trauma program by which we're trying to address internally a lot of these issues. But we need help. We need financial help. And if we can get that, then I think there's a good future for what happens there. If not, I have to look at my life and say, do I want to continue to do this? Do I want to continue to put out my or downgrade my lifestyle when I could go to another state or just get out of trauma and do an elective practice? And so, going back to it, not to be redundant, but I think we really need to create that market by which I'm excited about doing trauma care, which is what I like to do. Make it so that people want to come and take care of patients in the state of Georgia. And like to hopefully leave a few minutes for questions. So.
Thank you very much, Dr. Ziegler. We'll take just a moment or two if there are some questions for either Dr. Ziegler or Dr. Buchanan.
Sure. Primarily geared towards the emergency room and emergency room visits. What percentage of the emergency room visits at your facility do you think are non-emergency?
We've broken that out, and it's probably around 25%. Now, I'll stop you there because I probably know where you're going as to whether overcrowding, hospital overcrowding and things like that are related to non-emergency use of the emergency room. I think that if you look at some of the national people that are talking, I think when you look at the data, that's not the case. The overcrowding of emergency rooms, time and time again, is related to decreased inpatient capacity. We have, as I mentioned, 63 beds in our emergency room, and we've had as many as 24 of those beds being been held by patients who are admitted to the hospital waiting to get their bed. And you can imagine when you take more than a third of your efficiency and you lock it up and say you can't use that area, what happens to your hospital. And that is a big issue. If we were back up here in the wintertime, we would see that in almost every metro Atlanta hospital, that they're over capacity. And what happens is when you admit a patient to the hospital in the emergency room and there's no bed upstairs, they stay in the emergency room.
My question gets more to how do we penalize non-emergency use of the emergency room, or discourage non-emergency use of the emergency room?
One of the issues, one of the things that's going around, I believe Grady is now implementing, where people are briefly evaluated to determine whether they have a non-emergent or emergent problem. And if they have a non-emergent problem, they're offered care, but at a price, be it, I think the number I've heard they're going to use is $25 for in-county and $50 if you're out of county. I think that that's one way of looking at it. One of the problems is with the EMTALA rule that we've talked about, is that you have to evaluate somebody and stabilize any potential emergency condition before you discharge that patient or refer them to somewhere else. And it takes time to evaluate somebody and decide whether they have an emergency condition or not.
This question is for Dr. Ziegler. Well, first comment, thank you so much for what you do. As a trauma specialist surgeon, what percentage would you say of the patients that present to your trauma practice are uninsured? And what would you say? I've heard the number at Gwinnett alone, $40 million of uncompensated care, but then I heard $250 million statewide. That seems to be a little disproportionate number, but could you give me some estimates from your experience as to the compensated percentage and non-compensated percentage, and also there at Gwinnett in its entirety?
Definitely. I think we probably run in the emergency room, and Carlton can back me up on this, around 30% of uninsured patients. What we see is the financial status of the patient may change over time, though, because they may show up in the emergency room uninsured. That patient may turn out to be an auto insurance case that we do get paid for. They may end up getting on a federal assistance program like a Medicaid program subsequently, and that bill will be paid. You're also breaking down the bills for the hospital versus the independent practitioner. So there's a lot of ways, I think, to look at those numbers, and the numbers from Gwinnett may be patients who left the hospital once their bill was established and they were still uninsured. Maybe some of that gets paid for down the road, but we're certainly seeing a 30% number there, probably a lot worse at other places. And from my standpoint, it can really sap your time very quickly. Some of these patients require surgeries that are 8, 10, 12 hours long in the initial phase, and then multiple long surgeries. And there's only so many hours in the week. And if you're using up, 30% of your time doing uninsured care, you really can't compete with other doctors in your financial situation. And again, these are also not easy things to get paid for. For example, a patient who comes in with absolutely no insurance, yes, we may get them on Medicaid. Yes, we may get some car insurance. We have to hire significant additional staff and spend a lot of time to track these folks down, fill out forms, investigate their financial situation. And unfortunately, a lot of times they're less than cooperative. They feel like we should just be providing the care, and we have to track them down to help get them to help us get paid. I don't know if that answers the question.
Can I Can I make a clarification? That $250 million, I think, is what the Trauma Study Development Committee had quoted as for total uncompensated trauma care for this state. The $40 million that I quoted was our total indigent care, trauma, non-trauma, medical, all comers, obstetric, everything for our facility. What percentage of our facility is trauma? I would guess 25%. I mean, that would put us at 10 million, which being one of 15 trauma centers, that would probably fit that proportion of 240 million. So that 40 million, that was total indigent care. To follow up with the issue back on the CON issue as well, most hospitals have finite OR space and finite OR capacity. When you get to the point that your trauma care and your uncompensated trauma care is taking up space in your OR that could be used by, for compensated procedures, that also becomes an issue. Again, I think it goes back to if you're going to use the CON system to treat trauma centers slightly differently.
A final question from Senator Adelman.
Thank you, Mr. Chairman. This is for, it was Dr. Buchanan. I think I heard you recommend or, suggest as a potential alternative an insurance mandate covering the trauma activation fee. Can you help us quantify what the total dollars might be in Georgia? And I don't expect you to have it here, but if you can just send us in the right direction for the trauma activation fees that are not covered by insurance. What kind of money are we talking about if we were to pursue your recommendation?
Can I ask if Dr. O'Neill would, I think he's going to be the expert on that.
One of the problems will be that not every facility uses trauma activation fees. It's optional. And at the last time we checked, I think it was about half of the facilities were using it. So the data is going to be somewhat skewed.
I think you could work backwards, though, of looking at your payer mix for trauma, as in which one of those do have auto or health insurance, and then apply a trauma activation fee to a number of trauma visits statewide and include the ones that aren't using it to probably get a number.
If I could just very briefly, Mr. Chairman, how much is the trauma activation fee? Educate me on, for the hospitals that segregate such a fee.
It's extraordinarily broad. It ranges from $25 to about $2,000.
Yeah. When I was referring to it, I was thinking more of along the lines of what I believe ours is, which is approximately $2,000.
Thank you, Mr. Chairman. Thank you.
Thank you very much. We appreciate Dr. Ziegler and Dr. Buchanan being with us today. We thank you for your testimony and, more importantly, for what you do in your communities and in your hospitals for Georgians who have need of your care. We have come to the conclusion of this part of our meeting today. There will be lunch served for committee members in room 230 immediately following this. And then for those who are staying for the tours this afternoon, we'll be leaving very close to 12:30 or a little after that for brief tours of Grady and the Atlanta Medical Center. We'll have a chance to talk to some emergency room doctors at the Atlanta Medical Center, and we'll be back here or coming back to the Capitol at approximately 2:30. Let me also just remind everyone here, including the members and those of you who have interest in this issue, that our next formal meeting will be on September the 11th in Macon, Georgia, at the Mercer University School of Medicine Auditorium. We will have as our focus of that particular meeting disaster preparedness and homeland security. For the committee members, we will probably do as we did this time and have a committee dinner the night before. We'll give you information about that shortly and begin our meeting with breakfast and at about 8 and our meeting at about 9 a.m. on September the 11th. For those of you who are here, if you wish to give testimony to this committee, please let us know. Send either Chairman O'Neill or myself an email or a letter or a note of some kind. and let us know of your interest. As I mentioned earlier, we will have probably a full day of testimony on September the 25th in Savannah from stakeholders for this very important issue. Chairman O'Neill, any further comments from you?
I think you covered it well. Mr. Chairman, thank you, everybody, for being with us.
Thank you very much. Committee members, if you please go to room 230.